Okay, so now we are going to look at loop diuretics and other diuretics that act on different parts of the nephron. So first of all, just look at these parts of the nephron. This is glomeruli, this is PCT, this is loop of Henle, this is distal convoluted tubule, and here is collecting duct. So from glomeruli, proteins, glucose, and some other substances are going into the proximal convoluted tubule. From here, majority of reabsorption occurs of the ions, and then from loop of Henle, some other ions like sodium and potassium are reabsorbed, and from DCT, potassium and magnesium are reabsorbed. From collecting duct, majority of water is reabsorbed. So we use diuretics that act on the different parts of the nephron, like furosemide acts on the loop of Henle. When furosemide is used in excessive, hypokalemia can be developed. And when we use thiazide diuretics on distal convoluted tubules and hypertension, mostly we use thiazide diuretics. And collecting duct, we use spironolactone. It is used most commonly in heart failures, and it causes polyuria and loss of excessive water. So what are the findings that happens due to these diuretics? When hyperkalemia is developed, tall T wave is found on ECG. Hypokalemia is present with the U wave in the ECG. Hyponatremia presents with the seizures to the patient, and in acidosis occurs because excessive proton ion build up in the body or decreased ammonia excretion results into these findings. So now this is the simple basic structure. Here DCT is present, and potassium and magnesium are absorbed here. When there is deficiency of absorption, then it results into the alkalosis, because potassium is not absorbed and it is excreted out. It results into the alkalosis. Excessive sodium develop in the body results into the alkalosis. So loop diuretics act here on the loop of Henle. Furosemide is there. Sodium and potassium are absorbed. When there is failure, then results into the hypokalemia. Same alkalosis. Hypokalemic or metabolic alkalosis is developed because of loop diuretics. Okay, so here from this one we can look at glomerular pathologies are glomerular nephritis, diabetic nephropathy, and focal segmental glomerular nephropathy. It results into edema, hypertension, and hematuria. So hematuria occurs in the nephritic syndrome, and edema and hypertension most commonly occurs in the proteinuria and the nephrotic syndrome. Here in the PCT, Fanconi syndrome develops because of sodium, chlorine, and potassium absorption deficiency, or acute tubular necrosis can be developed. In loop of Henle, sodium and potassium are absorbed. When there is failure, results into the alkalosis, and also on thiazide diuretics acts on the distal convoluted tubule, and Gitelman disease develops here. Sodium, chlorine, and alkalosis develops. Little disease is associated with the collecting duct, and polyuria occurs when there is any deficiency in spironolactone or any pathology. Okay, so this one is the genetic diseases, nephrotic syndrome and nephritic syndrome differences. Nephrotic syndrome occurs because of podocyte injury, and majority is proteinuria, while nephritic syndrome is the capillary inflammation. Capillaries have blood, so when there is nephritic syndrome, capillary inflammation, hematuria is there, bleeding occurs in the urine. So in this way, these both syndromes are differentiated. And the next one is genetic disorders like Alport syndrome and adult polycystic kidney disease. Alport syndrome patient has hearing loss, and can't see, can't pee, can't hear a bee. This is the common mnemonic for Alport syndrome. Eye lens dislocation, urinary problem, and sensorineural deafness is there in Alport syndrome. Another one, adult autosomal dominant polycystic kidney disease is also genetic disease. It is dominant autosomal. So